Hi everybody and welcome. I'm going to give everybody just a minute to join in the session. Please remember there is a little bit of a delay, so when you ask questions and things like that, it'll take me just a minute to get back to you, but we definitely will get all your questions answered today. As you guys are coming in, I would like you to let me know where you're from, what school of nursing you're coming from, and that way I kind of have an idea of who you guys are and where you're from, all right? Hi, Jennifer. All right, so as people are coming in, I would like you guys to tell me what school of nursing you're from, or at least what state you're from, so I kind of have an idea of where you're coming from. So as people are joining in the session, there are still people requesting and things like that. So I'm going to talk to you guys for a few minutes before we get started on decoding lab values, which I'm super excited about. We decided to go ahead and make this a series because we've had so many students that want to learn about lab values. They don't understand lab values. They don't know what the levels are, how to remember the levels, and how to interpret them. So today's Decoding Lab Values session, we're going to completely decode the CBC, exactly what's in a CBC. I literally have students that will come in for a semester, or they'll be preparing for NCLEX, and they don't know what a CBC exactly does. They kind of know you just need to throw it at people, and we need CBCs on everyone, but they don't know why. But you have to understand that in order to understand how to get answers right on your exam, in order to understand, you know, what kind of patients need a CBC and to be able to understand what that means. Because our goal for you is to create absolute powerhouse nurses. So this isn't just a tutoring school. We want to make sure that you are super well educated, that you know exactly what you're doing, not only in nursing school, but once you get on the floor too. So we're going to go through a huge decoding of exactly what the CBC is, what's included in it, what's normal, what does it mean if it's high on a level? What does it mean if it's low on a level? And then what is the nursing care? Because it doesn't do you much good to just say, okay, the white blood cell count is low. Yay, okay, and that's it. It's like you have to be able to understand what your nursing care is, what your priorities are. This will help you on your exams, it will help you on the NCLEX, and it will most definitely help you whenever you get into practice. As nurses, yes, we want to be able to respond to lab values, but we want you to be able to prepare for something. That's what makes the best kind of nurses, and you'll see a lot of that in NCLEX, is that they want you to be able to anticipate care on your patient and prevent problems from happening before they happen, and we can do that through the CBC. The CBC tells us a lot, so we're going to start with that today. As you guys scroll down this Facebook page, I want you to be looking. We posted a couple things for you today. One, we're doing another Decoding Lab Values next week. We're going to be doing all the liver levels, the clotting factors, vitamin K, albumin, liver functions, alkaline phosphatase, all the GI and liver kind of labs, so that way you understand cirrhosis, you're understanding hepatitis. We're doing bilirubin. We're going to do all of those things so you understand what is this. Everybody knows if bilirubin's high, you're jaundiced and you turn yellow. Everybody gets that. But you have to understand what bilirubin is and what kind of signs and symptoms you'll see in your patient other than them just turning yellow, okay? So we're going to decode all of that. And for anybody that joins us during this session today, we're going to give you that session for only $5. Everybody else, it's a $25 fee. That's just, we have to, you know, pay the bills and keep the lights on and things like that. So we're going to be doing that one next week, and we're offering it to you guys for the next 24 hours. If you book it, there's a link on this page for you to book it. Only $5. If you keep coming to the sessions, we'll keep offering you those promo codes. Everybody else has to pay the full price of $25, but if you keep coming, you only pay $5 every time, as long as you come every single time, all right? So we wanted to do that for you. We don't want you to eat ramen noodles every day. We don't want you to have to set up mouse traps in your house because you're poor, and we get it, okay? I was a student too, and I literally had mice in my apartment. That's why I'm saying that. But I thought, dear God, I don't have to eat ramen noodles for the rest of my life, otherwise I'm gonna be a hypertensive mess. And I didn't, okay? Sometimes I don't eat ramen noodles. I eat pork rinds instead. Anyhow, so this is what we're going to be decoding today. This is our big focus, and then next week we'll be doing all the liver levels and everything GI. If you guys have certain lab values that you really want us to cover, because we're trying to set up the curriculum for the next couple of weeks, let me know what's confusing to you. That way we can set up a curriculum for it, and we'll have a session on that. CBC tends to be the hardest. Another one we're going to be doing, of course, is electrolytes, or the CMP, the Comprehensive Metabolic Panel. So we're going to go through that with you guys and help you understand that too. Before we do that session, I would highly recommend you go over to our YouTube channel. It is free, completely free videos, and you can watch there are 2 fluid and electrolytes videos on there. So before we do that session, make sure that you watch both of them. One of them is called Fluid and Electrolytes, which that might be easy for you to find. The second one is called Electrolytes Crash Course, and both of those are awesome. So make sure you subscribe to the YouTube channel. We do upload free videos every once in a while, so you want to make sure you get that new content, and we already have a ton of videos on there for you to study, okay? So I'm going to kind of see who's in here, who's coming, and sort of see what that looks like. So tell me where y'all from. Let's see who's here. I already said hi to Jennifer. Hey, Sunny. Patty's in here. All right, we've got somebody from ACC. Go Dolphins. Okay. Myrtle Beach. That's fantastic. We got some people from Tennessee. So we have people from everywhere, which is awesome. All right. So we're going to go ahead and start doing our CBC. So what I want you guys to tell me first, and this has got to be an interactive discussion. I need to hear what you guys know so that I know what to teach you, know what you don't know. All right. So always start with what you know. Tell me what you do know about a CBC. What does it stand for? What's included in it? Who do we use it for? Why do we use it? What is the purpose of the CBC? And while you guys are typing me that, I want to say something just across the board. This is very helpful for nursing exams. Do not ever give a rationale or say, oh, I just need to do a CBC for baseline. If your patient is coming into the hospital ill, that is no longer their baseline, right? That's not a baseline anything. That means they're sick, they're coming in, their labs are probably already altered. So a rationale for doing a CBC is never baseline because that doesn't make any sense. They're already sick, all right? If you're going to give me any answers today, I need a rationale, and I want you guys to start practicing that as you're going through and studying. If you just study cirrhosis causes bleeding, okay, but why? If you don't understand why, you really won't understand the nursing care. Why does cirrhosis cause patients to bleed? Well, the liver's responsible for producing vitamin K, clotting factors, platelets. So if the liver's broken, like it is in cirrhosis, you're not going to be producing platelets, vitamin K, clotting factors. Your patient's going to bleed because they don't have any platelets, all right, which we're going to talk about a little bit today. So the CBC is not just a we throw a CBC at everybody, we just want to know. There has to be a rationale and a purpose behind doing it. So that way when you choose it on the exam, you'll know exactly why you're choosing it. Second thing I want to tell you, just as a fun fact and for you to know, there hardly ever is a time where your priority on your patient is to run a lab. All right, there are very few nursing questions in the history of ever on exams, on NCLEX, that you will run a lab as the first thing you do for your patient. Labs take a while to come back, okay? So that's not helpful for me to do as the first line treatment. There's almost always something I can do first, and it's usually sit them up or do a pulse ox or assess your patient. It's gonna be anything else other than labs, all right? Very few times, I would say less than 1% of times is labs gonna be your number one priority, okay? All right, so I want to hear what you guys do know so that we can fill in with what you don't know. All right, so people are coming in saying it stands for complete blood count, which is actually, it does, but it's not a complete blood count, but it does tell us a lot. Tell me what kind of labs are in the CBC. I didn't write them up there so that way you could tell me. All right, so Elizabeth came in saying white blood cells, red blood cells, and platelets are a part of the CBC. Absolutely. So we're going to write those up here. They're definitely a part, and I'm going to post a picture of this afterwards so you guys will have it. So if you can't see something, because I'm going to have to write small in some places, as if I was one of those people writing on rice, okay? So if you can't see it, I'm definitely going to post a picture to the Facebook page so that way you can have it afterwards. So we're going to do the, oh, that's purple, I don't want that. White blood cell count. All right, so I want you guys to tell me what else you know that's in the CBC and kind of what it means and why we would do it, okay? So we're gonna do white blood cells here. So I want y'all to tell me what you know about that. We're gonna do red blood cells. Okay, we're gonna do a hemoglobin. We're gonna do a hematocrit. Okay, and these things we're all gonna decode, so don't be afraid if you don't know something. And then we're gonna do an MCV, and I'm gonna put all these together because they kind of mean the same thing. And nobody ever talks about MCV or MCH. They're the forgotten ones of the CBC, bless their heart. There's MCHC, okay? And then the last one would be platelets. All right, I want you guys to draw this on a piece of paper with me. I'm gonna give you about a minute and I'm gonna ask you to fill in as much of this chart as you can so you know what you already know, and then I'll tell you what you don't know, and then I'll tell you what you need to know. So write down, this says normal, so write me down what are the normal lab levels for each of these. Do not look them up, you're only going off of your memory. This has an arrow up, which means what does it mean if the white blood cell count is high? What does it mean if red blood cell count is high? Hemoglobin, hematocrit. So you're going to write what does it mean if they're high? How do we interpret that? Then you've got a down arrow over here, so what does it mean if they're low? And then you're going to do the nursing care for high and low for each. So I'm going to give you about a minute, so you better run, okay? And fill in as much of this chart as you can so you can see what you know. May the odds be ever in your favor. If you're feeling fancy, give me the term for highs and lows for each too, because we're going to cover that today too. Please impress me with your knowledge. All right, be sure to fill in exactly what you know. Search your brains. All right, we got a bunch of people that are joining us right now too, so. All right, you guys ready? Okay, for those of you that are just joining us, what I asked them to do, and you guys will be able to see this repeat later, so if you missed a few minutes, no big deal. I wanted you guys to get a piece of paper to fill out this chart and to fill it out best you can as far as what's high, what's low, what does it mean. We're gonna decode all of it, okay? And we're gonna have this available for you guys for the next 24 hours, so don't panic if you miss the first couple minutes. You all right, okay? Don't act like I don't come in late to class and miss stuff, okay? All right, so let's hit it and see what you know. Now, those of you who are Ivy League students and come here regularly, I'm expecting you to step up. Sunny, okay? I saw a bunch of you on there that are regular normal students that come to sessions all the time. So bring your A game and don't embarrass me, okay? All right, we're gonna start out talking about the white blood cell lab, all right? Tell me, what is a normal white blood cell lab? What would you expect to see? And I want you guys to kind of tell me, what did you write down about white blood cells? What does it mean to be high? What does it mean to be low? What's the term that we use? What's your nursing care? Tell me what you already knew about the white blood cells, okay? And this is pretty much the full CBC. The only thing we're not covering today is the differential, which we will cover. All right, Allison came in with 4.5 to 10. That's pretty good. I like that. Now you guys are gonna see that no matter where you go, you can go to a textbook, a PowerPoint, you can look at an ATI book, a HESI book, and you're gonna see different lab levels for each of these, okay? They're gonna be just slightly different, and that's okay. The ones that I'm going to teach you today, I'm going to do a mnemonic for you at the end so you can remember very clearly all of the levels of the CBC. So if my levels are a teeny bit different than what you're learning or what you see, that's normal for nursing school. It happens all the time. Even when you go into the hospital, you go to 2 different hospitals, their lab levels are going to be a little different, okay? So you just kind of need to understand what the highs and lows mean and don't focus and panic about one tiny little decimal number, okay? You will survive, all right? So an overall kind of normal for a white blood cell count is going to be somewhere between 5 to 10. Okay, and there's a rhyme and reason to why I'm doing these exact ones, and we will talk about that. So what does it mean when it's high? First of all, what's the term, and what does it mean if you have a high white blood cell count? There's 2 different things that could be happening here, okay? Allison came in and said high means infection. That is a possibility. So if they have a high white blood cell count, that could mean that they have some kind of infection, okay? What's another reason why you would have a high white blood cell count? Actually, there's a couple different reasons. And if you guys surprise me with ones I didn't think of, I'd be really impressed, okay? So white blood cell count. So what are we looking for? We're looking for a couple different things. I'm gonna let you guys answer. This usually is one of the big reasons why we do a CBC. I need to know exactly what's going on with my patient, and the main reason I usually do one, I'm a nurse practitioner, and so the reason why I would order one is to find out what's going on with my patient as far as infection and inflammation. That's the second thing, okay? So it can also be very elevated in an inflammatory process, and it doesn't necessarily mean that they have an infection at the time, okay? So it could be infection or inflammation. Like for instance, if a patient is in a huge rheumatoid arthritis flare, their white blood cell count may be high because of the inflammatory process. When the inflammatory process happens, it sends tons of white blood cells out to the area because it's like, I don't know if you're a bacteria, a virus, a clot, I don't know what you are, so I'm gonna send every part that I can to help you, and they will send a bunch of white blood cells out. And so in the inflammatory process, we can see that being high too. There's one other time where the white blood cell count may be super, super, super elevated. I'm talking, you pull up the CBC and normal is 5 to 10 and it may be 100, okay? One other thing I want to caution you guys on that people get confused on, normal says 5 to 10. When you actually get it on a CBC, it's in thousands. So it may say 5,000 to 10,000, but we shorten it to make it easier for us so we don't have to write all of the zeros, all right? So this is pretty normal for what you will hear in a report. You know, white blood cell count is 6, but that actually means the white blood cell count is 6,000, okay? Because if you only had 6 white blood cells, we're in big trouble. Like, we have all kinds of other issues going on. Does anybody know the other condition where your white blood cell count may be super ridiculously elevated? Anybody know? Come on, y'all. All right, I'll come back to that question to see if anybody knows. Okay. All right, Maria said pregnancy. Now, not during pregnancy. Sometimes after they give birth, the white blood cell count can shoot up for about 24 hours, but it shouldn't be super, super high, and it should come back down after 24 hours. I mean, your body just went through all kinds of holy hell. If y'all have ever seen a birth, you know that is not pretty, and it is rough, so that may happen. Allison came in and said stress, trauma, disease. Yes, but those are going to be part of the infection and inflammation process, all right? So because your patients are sick, there is a stress response, but there's one other condition where you'll see it super high, and I'm going to come back to it so you guys can think about it for a second and can write in. What is it called whenever the white blood cell count is super high? Let me get me a smaller marker. Hang on. What is it called if the white blood cell count is high? What's the term we use? Y'all, I said bring your A game today and I'm hearing nothing, all right? Tell me what you know. Where are my friends at? Why y'all leaving me out here alone? Help me. All right, if you had to Google it, okay, you would see that it is called, I know there's a little bit of a delay, but I waited a long time and y'all are still just hanging out, okay? Leukocytosis, all right? So leukocytosis is high, all right? So that means that the white blood cell count is high. They have either an infection going on, an inflammation going on, something is happening. So the white blood cell doesn't tell us everything. All it tells us is you either have an inflammatory process or you have an infection. How helpful is that for our patients that come in? Because most of them are coming in because they're sick, right? So this is where the differential will come in, and we will cover differential on another part of our series. The differential is where it tells you what kind of white blood cells are coming out. Eosinophils, basophils, neutrophils, what kind of white blood cells are coming out, because that will tell me what kind of infection that they have. So all this tells me is infection or inflammation. I'd have to do the differential. It's called CBC with diff, all right? And if the eosinophils were super high, that means they have a huge allergic process going on, or maybe anaphylaxis, and that's why this is super high. Are they in an infection? No, but they have an inflammatory process from anaphylaxis. If their neutrophils are super high, that tells me they are about to spike a big giant infection and I better get some antibiotics ready. I better look and see what's going on with this patient because they are sick, okay? If the basophils are really high, that tells me they either have an allergic thing going on or parasites. Okay, I don't do that kind of thing, okay? I don't like worms. It's just not my favorite thing except for gummy worms, and those are good as hell. All right, so what have we learned so far? White blood cell count, normal 5 to 10. We see it high in infection and inflammation. It's called leukocytosis. What is, let me see if anybody knew the really, really high white blood cell count. Nope, not a one human being. Leukemia, y'all, leukemia. So leukemia is a cancer of the bone marrow, and what happens is, since it's a cancerous process, it has all these white blood cells that form inside the bone marrow. They crowd out the red blood cells and the platelets, and all you have is white blood cells. So in a patient with acute leukemia, like we in it, you do a CBC and you may see that their white blood cell count is 100,000, 150,000. It's ridiculous, okay? And you'll see the other portions, the platelets, red blood cells are all crowded out and they're low, and okay? But that's acute leukemia we'll put up here too. All right, tell me what you know about low white blood cell count. What does that mean? How do we interpret that? And I want y'all to already be thinking about your nursing care. Come on, y'all. Nobody knows a thing. Okay, somebody came through and said something. Cancer. I'm going to agree with you on that. And it may not be just cancer per se, because a lot of times cancer can cause a high white blood cell count, but if they're on chemotherapy for cancer, then a lot of times we will see the white blood cell count be low, okay? And why would that be? What's chemotherapy's job? Chemotherapy's job is to go in and kill cancer cells, right? But it doesn't know which cells are cancerous and which are not. It's not that smart yet. We haven't evolved past that yet. So it goes in and kills all the cells. So it'll kill my white blood cells, my red blood cells, my platelets. It wipes you out because it's trying to just kill cells. It will kill the cancerous cells in the meantime, but it also wipes out all of your cells as well. So it would be very low if we were on something like chemotherapy, or if we were preparing for a bone marrow transplant where we need to wipe out all of their bad cells so that we can put in new, healthy, beautiful cells, or a stem cell transplant. That can cause it to be, or that we'll see low. What else do you guys know? Why else would it be low? And what is it called whenever it's low? Ah, Maria, out with the viral. Yes, girl. Okay. So a virus usually causes a low white blood cell count. Not every single virus, keep in mind, but a lot of viral things will. So I'm a pediatric nurse practitioner. I see children's, okay? So if a kid came in and mom said they've had 5 days of 104 fever, that could be flu, which is a virus. It could be something horrible like Kawasaki's disease, or it could be they have pneumonia. I have to know how to treat my patient. So I would run a CBC to kind of find out what's going on. If this was, let's say, a 2-year-old and they didn't have a ton of other symptoms, except for they just feel crummy, they're not wanting to eat, white blood cell count is super high, that tells me they've got a really bad infection and I need to find out where. So I know it paused for a second. Do not panic. Do not panic. I am back. Okay. If I looked at the CBC and the white blood cell count was low, that would tell me that there is something viral going on, like maybe they have flu or something like that. So if I got the CBC back, and keep in mind when I say low, I'm talking like 2.3, 3.2. If they have a white blood cell count of 0.1, they have cancer. Like that is almost always what we're gonna see, especially leukemia. Because what will happen with leukemia, we talked about it earlier, the white blood cells go super high, right? And they crowd out everything else. Then these white blood cells are immature and they're crummy and they don't work well. And then eventually your body, because they know they don't work well, they lyse them, they deplete them, and you may see a super low white blood cell count. So leukemia can go either way, okay? So we're gonna put it across both of these so that you understand that that can happen, okay? So what I want you guys to do now that you understand white blood cell count is tell me what am I gonna do? Oh, wait, one more thing. Tell me what's it called whenever they have a low white blood cell count. We said high was leukocytosis. Okay, low is, I'm not even gonna ask because y'all failed me last time, okay? Y'all need to get some coffee and wake up. Leukopenia, okay? So penia means teeny tiny, okay? So little, not a lot, leukocytes, just little, okay? So that's the term for low. So I want you guys to tell me if I have a high white blood cell count, what's my nursing care and what am I gonna do? If I have a low white blood cell count, what's my nursing care and what am I gonna do, okay? All right, now Allison said neutropenia, which I want to touch on for a minute because you may hear people call it neutropenia, but neutropenia means my neutrophils are low. And leukopenia, that means all my white blood cells are low. Both can exist at the same time, all right? Usually we use the term neutropenic for our chemo patients because their neutrophils are so super low, which does make their overall white blood cell count go low too. But neutropenia is a little bit different than leukopenia. Leukopenia means all white blood cells are low. Neutropenia typically means your neutrophils are low. And since your neutrophils are your fighters, right, they're the first ones out on the scene whenever you have an infection, those patients are at high risk of infection, right? So I want you guys to talk to me about that and how that impacts your nursing care. What do y'all know? All right, so Ray Maria Steele says treat infection for high. All right, but first we're gonna have to go looking for the infection, right? So I need to do a differential so I can see where the infection is. If they do have an infection, I'm gonna need to treat it with antibiotics, right? Right, I know, okay? So if it's high, we're gonna treat them with antibiotics. If it is just a inflammatory process, like say it's RA or it's a, something that's a huge inflammation, they're having an asthma attack, those kind of things, those inflammatory processes can cause it to go high, then you would need some corticosteroids, okay? So if it's high, we know we need to treat the infection. Now, some fun facts or some pearls of wisdom for you. On nursing exams, there are a couple of big things that you need to know that are on every exam in the history of all time, all right? Like, for instance, if you have a patient that you even suspect has meningitis, okay? The first thing you're going to do is precautions, right? Because you don't want it. You don't want your whole ER waiting room to have it. That stuff's nasty. The second thing is to administer antibiotics. So if it's a huge, giant infection, one of the most important things always on nursing exams is to administer antibiotics. The faster we get the antibiotics in the patient, the better that they do. Another instance where we would administer antibiotics almost immediately would be sepsis. Because we can try to treat this inflammatory process with sepsis, but if we don't stop that bacteria from growing, the patient will die of septic shock. So antibiotics are super important, especially if they are having a really high white blood cell count, okay? All right, what about low? If they are low in white blood cell count, we know that they are at high risk of infection, right? If they're at high risk of infection and their white blood cell count is truly low, then we usually will put them on neutropenic precautions. Tell me what you know about neutropenic precautions. And I saw somebody already said good hand washing, which is going to be number one, always and forever. If hand washing is on your exam, I would just put good washing. Just wash stuff. Good washing of the hands. I think that's weird later. Hand washing is always number one. If it's on your exam, pick it, because there's never a time where washing your hands is a bad idea, okay? Hand washing, neutropenic precautions. They're going to be high risk of infection, so we need to watch them for what vital signs too. I want you guys to tell me that too. All right, Allison comes in with no live plants, no fresh fruits. All right, so neutropenic means that they're not able to fight normal infections like we are. They're not able to really even fight normal pathogens like we are. So if I got up this morning and I ate yogurt that has live bacteria in there, my gut likes it, it's happy because it can fight off any bad bacteria, and it knows exactly what the good bacteria looks like. When your immune system is wiped out and you're neutropenic on chemotherapy, your immune system has no idea what's going on, okay? It cannot fight off those natural bacteria that we usually get. You pick up an apple, even if you wash it, it's got bacteria all over it. Our gut is made to kill all of that bacteria, but somebody who's neutropenic can't. So, no fresh fruits or vegetables. No yogurt, because it's got live lactobacillus in it, right? They can't have sushi, obviously. That is the worst life ever. I cannot imagine. I'm so sorry for people that have that. That is so hard. They cannot have any fresh plants, any live plants. Fresh plants? Where do you get fresh plants? Live plants, that's what I meant. You know what I meant. Because that has fungus. So especially like our HIV, AIDS patients, those kind of things, they like to ask questions about no fresh plants. They can have fake plants, but no fresh plants. And they cannot garden. Gardening is huge on the NCLEX. Don't ask me why. I don't know if all these people in the world are just out gardening. I'm not. But gardening is a big issue. So if your patient is immunocompromised or neutropenic, they have low white blood cell count, do not let them go out in the garden because of all the fungus. Do not let them have fresh plants. Meats have to be super cooked, okay? So those are what's considered your neutropenic precautions, all right? Everything has to be pasteurized. All right, and Ashley said watch for fever. Absolutely. A lot of times on NCLEX and on your exams, okay, this is a priority. You have a patient, let's say a 47-year-old patient diagnosed with acute lymphocytic leukemia. The patient's white blood cell, the patient's CBC came back this morning, at a white blood cell count of 0.2. Okay, we expect that because they're on chemo. All right, which of the following, or what are you going to do first? Or they may also ask which of the following patients may you see first. If it is a neutropenic patient that all of a sudden has fever, and for NCLEX purposes and all across the board through nursing school, fever is 100.4 or greater. Anything below that, not a fever. Now try to convince like great Aunt Sally that she doesn't have fever with 100.2 and she usually runs like 91.2. That's what they'll tell you when they come in the ER. Like, yeah, but I usually run like 12 and I have a 99.2, so that's a fever for me. Okay, all right. But a fever for NCLEX purposes is 100.4, all right? So if a patient who is neutropenic all of a sudden has a temperature greater than 100.4, you need to hurry up and get in that room. We need to look at the CBC, find the source of the infection, and treat it aggressively because they have no immune system to treat that infection, and they could go septic and die very, very easily, okay? That was a bummer to end on. Dum, dum, dum. Okay? All right, do we understand white blood cell count and kind of what to look for and what it is? We'll talk about differential, like I said, on one of the other seminars that we're doing in the series. Let's talk about the red blood cells. People kind of know what this is, and I know it seems super easy, but interpreting it is a little bit different, okay? So I want you to tell me what you know about red blood cells. What's my normal? What's high? What's low? What does it mean? Help me, okay? Tell me what you know. You should have filled some of this out from your chart already. So y'all should give me something. All right, so people are coming in somewhere around 4 to 6 is about normal. I like that. Okay. So, red blood cells, what do they do? We are going to put a normal. I like 4 to 5, and I'll show you why later if you can just trust me with your heart and your nursing school education. So, red blood cells, what's their job? All right, so red blood cells are a solid portion of the blood, and that's important for you to remember when you're talking about high and low, all right? Red blood cells are part of the solid part of the blood, right? The plasma is the liquid and the water part. So, red blood cells, white blood cells, and platelets, and clotting factors, a couple other things, make up the solid portion. Plasma is the liquid, all right? Red blood cells' job is they have hemoglobin on them. Hemoglobin's job is to bind oxygen. You guys should know this already, okay? Where people go wrong is they think that if people have low red blood cells, then that means they're at risk for bleeding. Nada. No. Stop it. Platelets are bleeding. Red blood cells are not bleeding, okay? Red blood cells, their job is to make sure there's hemoglobin and to make sure that you get oxygen and perfusion to the tissues, okay? Solid portion. I've said it 50 times, that way you know what goes up here, okay? So if normal red blood cell count is 4 to 5, so red blood cell count does not give us an indication of bleeding. It does not mean your patient's at risk for bleeding. This is an oxygen issue, okay? That's like a pet peeve of mine, kind of like when people say aspirin's a blood thinner, and then I almost die inside because it isn't, and if you think it is, let's talk later, okay? All right, so red blood cells, normal is 4 to 5, so we got hemoglobin on them. We also have to have iron that binds to it in order for the hemoglobin to have oxygen to stick. There are a couple of other minerals and things that are really important for red blood cell health, all right? Vitamin B12, actually all your B vitamins kind of help make healthy cells, especially B12 is going to make healthy red blood cells. Folic acid is the second thing that makes healthy red blood cells. So you have to have in your diet or in your body somehow folic acid, vitamin B12, okay, and iron in order for your red blood cells to be healthy and to function as normal. If they are not functioning as normal, then you're going to have a breathing or an oxygen issue because that's what red blood cells are. They carry oxygen. Are you with me? Do red blood cells cause you to bleed? No. Stop it. Okay? All right. So if we know normal is 4 to 5, what happens when the red blood cells go high? What is that? Now think about me saying it's a solid portion of the blood. Now you have a ton of solid portion of the blood. What does that do to my viscosity? What does it do to the viscosity of the blood? Is it going to be thicker? Is it going to be thinner? What does that look like? Hint, thicker, okay? So that is called, we're going to have increased viscosity, which tell me what would that do to your blood pressure, and tell me what is the disease process, what's the term that we use when a patient has a whole bunch of red blood cells, and then what are they at risk for? That's what I want to know. So, 3 things. What disease process is it when they have really high red blood cells? What happens to the blood pressure? I already forgot the 3rd thing. Oh, what does that put them at risk for? Okay. All right, so Sunny in with the increased BP. Absolutely. Allison says polycythemia. All right, so here's what's going to happen. If it is really high, we call it polycythemia. Poly means many. Cyth means cell. Emia means blood. So high cells in the blood. High red blood cells in the blood. All right. What that's going to do is that can also give us hypertension, because if we have an increased solid portion, the viscosity is going to be increased. Think of it like a water hose. If I'm trying to put water through a water hose, it's going to go through beautifully because that's what the water hose is for. If I try to put peanut butter through it, increase viscosity, it's thicker, it's gonna take a lot more pressure to push that peanut butter through. That's why the blood pressure will go high, okay? So when I see a red blood cell that's high, it doesn't mean like, oh, patients that are hypertensive have high red blood cells. Could that happen? Possibly, but it's not causal. Do you see what I mean? If I know they have polycythemia, chances are they do have high red blood cells, okay? And hypertension. All right, so we know this is polycythemia. We know that they can get hypertension from it. What does that put them at risk for? There's actually a couple things that they're at risk for if they have polycythemia. Sunny with the clots, Maria too. All right, so since it is thicker, it is more viscous, there's tons more cells in there, they are at high risk, okay? So I'm gonna put this underneath here. They're at risk for clots, okay, because you got a lot more solid portion. If their blood pressure goes up really high for it, they're also at risk for stroke, right? Which is a form of a clot anyway, yeah. All right, so you've got hypertension, clots, strokes, all with polycythemia. There are some disease processes that can cause polycythemia, but there's also a primary disease called polycythemia vera, where they get it as a primary disease. All right, now what is low red blood cells? What happens, or what's the issue with low red blood cells? Come on, y'all. And then interpret that for me. All right, we got anemia. Not enough oxygen to perfuse tissues. Good job, y'all. All right, that's it. Okay, so if it is low, and remember too, I'm gonna be real careful writing this up here because we don't use red blood cells as an indicator for anemia, even though it could indicate anemia. But there's a lot of times when your patient does get anemia, your body recognizes, oh, I don't have as many red blood cells, and so it tries to overproduce. What organ is responsible for making a hormone that produces red blood cells? Does anybody know? What is the organ? What is the hormone? Okay, they may need a transfusion. That's a possibility. But I want you guys to be very clear that we don't use red blood cells as an indicator for a blood transfusion, and we don't use them as an indicator for all anemia, okay? And the reason why, like I said, if your body is not producing enough red blood cells, this organ is going to produce this hormone, which you're going to tell me in a second, and your body may make a normal amount. So if you have a patient that has iron deficiency anemia, it is likely that you could do a CBC and the red blood cell count is normal. So red blood cells do not tell us a whole lot because you can have a little bit of red blood cells, but they're big and they can bind lots of hemoglobin. You may have big red blood cells that don't bind a lot of hemoglobin. So it's not the red blood cells that we're most concerned about. It's the actual hemoglobin on there that can bind to the oxygen. So is it a possibility you could have low red blood cells with anemia? Yes. But there are some anemias where you have high red blood cells, they just don't have a lot of hemoglobin on them. Okay, so I want to be clear about that. Good job! Oh my gosh, y'all are waking up finally. Okay, so kidney problems and erythropoietin. That's it. That's exactly what I was looking for. So your kidneys are responsible for producing erythropoietin. Erythro means red blood cells. Poietin means to make red blood cells. I told you exactly what it was, okay? So when your body gets hypoxic or it needs more oxygen, it signals your kidneys to produce erythropoietin, which then goes into your bone marrow, produces more red blood cells, and then it should turn off that hypoxia. What happens in chronic conditions like COPD, they're always hypoxic. And no matter how many red blood cells I make, they're not gonna not be hypoxic, right? So that cycle is gonna keep going over and over again. Okay, I'm hypoxic, I go to the kidneys, I need erythropoietin. Erythropoietin goes into the bone marrow produces more red blood cells. But I'm still hypoxic, so we keep going in this circle. So a lot of patients with COPD may have polycythemia. So they almost turn like a purplish color. Okay, that's weird, why? Well, polycythemia patients typically turn a little reddish because they have a lot more red, a lot more solid red portion of the blood. COPD patients are a little cyanotic, red plus blue is purple. Okay, remember in second grade when we learned primary colors? It was so much fun. We're gonna visit it again today, all right? So anemia I'm going to put up there, but I want you to remember that red blood cells are not our best indicator of anemia, okay? Now we can put a hypoxia up here, because remember red blood cells I want you to associate with oxygen. Oxygen, red blood cells, oxygen, okay? So it may be that they are hypoxic, It may be that this causes hypoxia, but red blood cells have to do with oxygen. Have I hammered it in enough? So I want you to tell me, what do I do for a patient that has high red blood cells? What do I do for a patient that has low red blood cells? Nursing care. You don't have to just give them medicines. I want to know, like, the nursing care, what you would do. Okay, I'm seeing some people put some stuff in here, blood thinners, iron infusions, administer oxygen. Okay, I want y'all to be careful with some of the things that you're saying, because think of it this way. If a patient has polycythemia vera, they have a lot of red blood cells, they have a lot of iron, we do not want to give them iron, okay? Now, if they have iron deficiency anemia, we can match up the iron. Be very careful on your anemias, okay? If you guys have exams on anemias, I want you to be super cautious. We do not throw iron at every anemia. There are some anemias where it can be dangerous and even fatal to give a patient with anemia iron if they do not have an iron deficiency. The biggest one I can tell you about is sickle cell anemia, because sickle cell patients get so many transfusions, they get so much iron, they can go into iron toxicity and they could die. So we never give them iron. So on your exams, make sure you only match up iron supplements with iron deficiency anemia and not just anemia as a whole, because you could do your patient a huge disservice, like killing them. And we try not to do that. Don't stop it, all right? So let's talk about the polycythemia. So you could give blood thinners, but is it gonna do any good? Not really, because blood thinners really work on our clotting factors. They don't just thin out the blood. They don't get rid of the red blood cells. They don't do any of that. So if it's high and it's polycythemia, think about your nursing care, all right? They're gonna go on like neuro checks, because if we're worried about stroke and clots, we need to put them on neuro checks so we can make sure that they're not having any stroke symptoms, okay? Wouldn't that be important? We're gonna put them on seizure precautions. A lot of times whenever people stroke, they can also have a seizure, so we're gonna make sure your patient is well taken care of. You're gonna be doing Glasgow Coma Scale, right? So we can make sure that there's no stroke going on and watch them for signs and symptoms of that. We also have to watch blood pressure, right? So we're gonna watch that hypertension if they have polycythemia, because we may need to give them something to bring down that blood pressure, right? Because we do not want them to stroke out. Remember, the worst case scenario of hypertension, super high pressure in the vessels, it goes to the teeny tiny vessels in the brain, it can blow them out and cause a hemorrhagic stroke. That's why we worry so much about blood pressure in all of nursing school, okay? So if you get a question on your nursing exam, what do we do when a patient has really bad hypertension? Neuro check, seizure precautions, bah, okay? We do not want them to stroke out, okay? So most of this stuff, if you can see, that doesn't seem like it matches up, because it's polycythemia, that's a blood thing, and we're doing mostly like neuro stuff, which seems weird, but it's correct, okay? All right, if they have low red blood cells, we need to be looking for why, okay? And both of these, we're gonna be looking for the why, okay? Because I have to treat it, all right? Treating the cause for the red blood cell problems is much more effective than trying to prevent things from happening. Do you see the difference? So if it's low, it may be a possibility they have anemia. That's a possibility, okay? If they do have anemia, which we would only know by our hemoglobin and hematocrit, okay? Tell me, what is your plan of care for patients that are anemic? What's your nursing plan of care? Check O2, vitals, risk for falls. All right, I can go with some of those. But you have to give me a rationale why, because if you just choose vitals in the exam, we don't know what are you looking for. In anemia, right, we don't have very many red blood cells, so the solid portion of our blood is less, so our viscosity is less, which means you may have hypotension, which is why somebody said risk for falls, which is nice. So we're gonna put them on fall risk, okay? We are gonna monitor their BP for hypotension and tell them change position slowly, right, because they may have orthostatic. We need to find out the cause of the anemia so we know how to treat it. So we're gonna be doing a whole bunch of other stuff, which we'll cover on another day, like iron levels, ferritin, all of those things. Change position slowly, fall risk, BP, we need to have them on an SpO2 monitor, okay? Because if they're at risk for hypoxia, we need to know if they're hypoxic, and then if they are hypoxic, we're gonna administer O2. They also will tell you for the anemia plan of care, make sure that they have frequent rest periods, okay? because they're going to be tired and they're going to have a hard time doing a whole bunch of stuff, okay? All right, do we understand red blood cells? Have we made it clear enough that it's not our best indicator of anemia? Solid portion, blah, blah, blah. We got this, okay? We will do iron supplements if it's iron deficiency anemia, but we won't know until we get down to our hemoglobin and hematocrit. Somebody said B12 injection, which we will only do if they truly have B12 deficiency anemia, which is pernicious anemia, okay? And sometimes actually in B12 or pernicious anemia, their red blood cells can look high, or they can just look, they can be small or big. So like I said, red blood cells has a lot of variability. So don't use that as an indicator to make your decisions. Our hemoglobin and hematocrit are how we make our decisions, okay? So I want you guys to tell me what you know about the H and H. That's what we call it, H and H, hemoglobin, hematocrit. What are they? What are their normal levels? What do they mean? Tell me what you know, please. I just want y'all to know when I'm over here, I'm leaning on a chair and it makes weird noises. It's not my body making the noises. It's just the chair, okay? Don't write us a letter. All right. Allison, female 12 to 16, male 14 to 18. Yes, and remember with these, you're gonna see a huge variation. I'm gonna give you a large variation, okay? And the reason why I'm doing that is because they're not gonna ask you right in the middle of the hemoglobin. Hemoglobin and hematocrit are our best indicator of how well oxygenated the patient is. Is there bleeding? That's what we're looking for with hemoglobin and hematocrit, okay? A normal hemoglobin, I want to tell you, is somewhere, and I'm going to give you just a red flags to look for, okay? You can spend the time trying to memorize every single number for male and female, blah, blah, if you want to. I don't. Sounds horrible. So I'm going to give you the red flags that they will put on an exam that you'll know, like, okay, this is bad, all right? So a normal hemoglobin-ish is going to be somewhere between 11 to 15. Hemoglobin actually gives us the amount of hemoglobin that is on the red blood cells. Hematocrit tells us the percentage, okay? They are always going to go together. There is no way that you can have more of something and less percentage of it. It does not make sense, okay? So hemoglobin and hematocrit will go together, and these are our best indicators of bleeding, anemia, those kinds of things, okay? So I'm going to give you about 11 to 15. Hematocrit is our percentage. That's going to be somewhere between 30 to 45%, okay? These are gonna go together, okay? Now, this is one of the only times where I will tell you, you can say baseline, but you still have to give me a rationale, okay? And the reason I say that is because there's a lot of exam questions in nursing school where they'll say, a patient went into surgery, their CBC pre-op, hemoglobin was 14.2, 1 hour after surgery, you draw another CBC, hemoglobin is now 8.2. That patient bleeding, okay? And we have to do something. So they will usually have to give you some kind of baseline before, but it has to be when they were somewhat well. That means before surgery, all right? Hemoglobin can give us a big indication of bleeding, because if I'm bleeding somewhere, and it could be a slow GI bleed, it could be a gunshot wound, it could be whatever, I'm losing a lot of red blood cells and hemoglobin with it. So hemoglobin and hematocrit is what we use to determine whether the patient needs a transfusion or not, okay? These are going to go together, so I'm going to put them together like this. So what does it mean, or interpret what would happen if your hemoglobin and hematocrit were high? Like, what do you tell your patient? Like, you're so good at oxygenating. Like, what's the purpose, why, and what are we kind of looking for? Decode this, please. What do y'all know? Come on, hit me with your best shot. I won't sing, but I want to sing. I just want y'all to know I want to sing that song so bad to y'all right now. But not a lot of you know me, and you think I'm weird. All right, so if hemoglobin and hematocrit, so hemoglobin binds to red blood cells, right? Right. Okay. So the hematocrit is giving us the percentage to water. Okay. So I'm going to draw something and then I'm going to erase it just so you can kind of understand. I'm going to draw this cup here. Okay. Keep in mind I'm not an artist. God did not bless me with that. I know medical stuff, but I'm not like Commander Mark. Okay. All right. So this is a cup. Okay. And let's say I fill this cup with some water, which is the liquid portion of our blood. I have no blue over here. Hold on. So plasma is the liquid portion, but I'm going to do it as water, okay? So let's say you have some water in your blood, okay? And you also have red blood cells. All right, so here's my red blood cells. So the hemoglobin is telling me how many of these circles I'm drawing, okay? The hematocrit is going to tell me what percentage of what's inside this cup is red versus blue, okay? Do y'all see what I mean? I can't hear you, so I'm hoping you're saying yes, okay? So, now what will happen, all right, we understand the concept. The blue is the plasma, the red is the red blood cells. So the hematocrit tells us at what percentage are red blood cells in the entire blood, right? So what would happen, because we're looking for high, if I took out this water, but I didn't add any more of the red. So I just took all of this out. That would give me a higher percentage, even though I didn't change the number of red blood cells. Do you see what I mean? Okay? So if our hemoglobin and hematocrit are high, it almost always means because we have less water and not because you're producing more hemoglobin and hematocrit, because that would make our red blood cells go high, right? Do you understand what I mean? So the percentage only changes because you have less water. What condition means less water? What means less water? If your patient comes in with no water in their body, then they are blank. Ah, thank you, Ashley and Christy and Patty. Okay, now y'all are coming through. Maybe I'm just not giving you enough time and I'm just mean and like, tell me now. All right. So that means that they're dehydrated. So almost always if hemoglobin and hematocrit are high, that usually means the patient is dehydrated. So they have dehydration. We don't call it that exactly, but if a patient does come in really dehydrated, let's say they had a horrible stomach bug, they made some bad decisions and went to a shady restaurant and got some sushi that was questionable, and then they've been having severe vomiting and diarrhea for the last 24 hours. They come in, they look like crap, you know, eyes are doing some weird sunken things, and they're really, really dehydrated. Then their percentage of water has decreased, which makes it look like the percentage of hemoglobin and hematocrit are going to increase, right? Or the percentage of red blood cells is going to increase, okay? So we call this, and you'll, this is on exams all the time. Hemoconcentration is what it means. Hemo means blood, concentration, increased concentration. So your blood is more concentrated because you have less water. Do we understand that concept? Okay? We just tell them drink some more fluids or give you some IV fluids, stop going to the shady sushi places, get your life together. Okay? All right. What would it mean if the hemoglobin and hematocrit then is low? What is it? All right, hemoglobin and hematocrit low could mean so many different things, okay? So it could mean that the patient truly is anemic, because remember, anemia, we look more at the hemoglobin and hematocrit and not at the total red blood cell count. Because the red blood cells can look super funky. They could be of a normal amount, but they could be small and pale, which is like hypochromic or microcytic, or they could look all kinds of jacked up. So we really don't want to see how many you have. I want to see how well your body is able to, or how much hemoglobin your body has for oxygen to bind to. I could put out all the red blood cells in the world, but if it didn't have good hemoglobin, it doesn't do me any good, okay? So anemia is a big one here if this is low. You could also have it low from straight up blood loss, okay? And what they like to ask in nursing school a lot is you have a patient that's been on aspirin therapy for the last 3 years, and then you do a CBC on them for their yearly physical, and you notice that the hemoglobin is 8, okay? Well, that means it's low. Something is going on. I would probably want to do a Hemocult stool to see if they're bleeding in the gut. So you could have an actual slow bleed through the stomach or through your gut. Aspirin is notorious for causing peptic ulcer disease and gastritis and irritation and GI bleeds. So that would be something I would be looking for. Also, fun fact, never pick blood in the stool if it's like occult blood or any kind of like very slow GI bleed. That's never your priority. It took them 3 years to get this GI bleed. You have other things that you can do in other patients you need to go to before you would go to that. People usually see bleed or, oh my God, and they panic and they freak out, okay? If the patient is oxygenating well, I don't have to run to that patient, okay? And just so you know, all right, even though I put hemoglobin 11 to 15, that's probably closer, like maybe, I don't know, 33 or so. 30 is just kind of on the lower side. Anyhow, something like that, it doesn't matter. We'll get to that in a second. If this is low, so it could be from blood loss, if it's a slow GI bleed, that's not your priority. Now, if they have bright red blood or they've been in a motor vehicle accident or something like that, okay, blood loss, I'm gonna go a little bit faster on, okay? If you look at the hemoglobin, this says 11 to 15. Now, that's normal, but if a patient is 10, we don't do anything. I'm not gonna run to that patient. They're still, as long as they're oxygenating well, we happy, okay? Somewhere around 8, we get a little like, I don't really like it. We probably would go ahead and put them on a pulse ox, make sure they're not hypoxic, do all of those things, and then find a reason why their hemoglobin is so low. Your red flag number is 7, because across the board, almost everybody in the history of ever, if your hemoglobin goes below 7, that's a giant red flag, and you need a blood transfusion at that point, okay? So I'm going to put your red flag lab less than 7. Okay, so that's scary, all right? Remember, your hematocrit's always going to match that, so all you have to know is the hemoglobin. All right, so low could mean anemia. It could be from blood loss. It could be, leukemia. We talked about that earlier, right? Remember with leukemia, they form so many white blood cells, it crowds out all the red blood cells, the platelets, so their hemoglobin and hematocrit are going to be very low. This can also happen with chemotherapy patients, okay? Because remember, we talked about earlier, chemotherapy knocks out all your cells, so their cell lines will be low, they're at risk, okay? What else? Let's see, chemo, bleeding, leukemia, anemia, what am I missing? They are going to be at risk for what? Remember, hemoglobin and hematocrit do not make your patient at risk for bleeding. I want to be very clear on this, okay? This is huge. Look at me in my eyes, okay? Hemoglobin and hematocrit, if they're low, does not mean your patient is at risk of bleeding. Now, it is a possibility they could have had a bleed that led to low hemoglobin and hematocrit. But the hemoglobin's job is oxygen. Oxygen, 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 just like we talked about with the red blood cells, okay? Okay, hold on. I'm going to repeat what I just said. Hemoglobin and hematocrit, oxygen, 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 okay? If you are low on hemoglobin and hematocrit, we are at risk of hypoxia, not at risk for bleeding. Bleeding is going to come down here in the platelets, right? So if we know these things, okay, then I want you to tell me, what is my nursing plan of care if I am high? Not if I'm high. Don't give me my nursing plan of care if I'm high. Most people ask me if I'm high most of the day because I talk so fast. I'm from Texas. I'm not, okay? Don't give me that plan of care. If the patient's hemoglobin and hematocrit are high, what is your nursing care? If the patient's hemoglobin and hematocrit is low, what is your nursing care? I'm going to give you a minute to tell me what you know, okay? Go based off what it means, and then you can do your nursing plan of care off of that. All right, so people are saying maybe some fluids, monitor O2, check their blood pressure. I love everything that you're saying. Y'all are making me happy now. At the beginning, I was a little worried about you, but you move in now. All right, so let's say it's high. If they're super dehydrated, of course, they're gonna need IV fluids, and that usually should just take care of it. However, we do have to monitor blood pressure, right? because if hemoglobin and hematocrit are high, that means hemo concentration. Their viscosity may be a little bit higher, but their fluid volume overall is so low, they may actually have hypotension, which is a super weird way. But you do have to watch for BP, right? But most of the time we can fix this either with IV fluids if they're severely dehydrated, or if this was just a random CBC that we did, not random because I told you don't do that. Say they're coming in for their yearly physical and they did a CBC, or they did a CBC for another reason, and the patient's hemoglobin and hematocrit were high, I would tell them, you'll just need to drink more fluids. It looks like your blood is a little bit thicker than we would expect it to be and you're not staying hydrated, okay? So IV fluids and blood pressure. Now what would I do if hemoglobin and hematocrit were low? Keep in mind your red flags, when we worry, those kind of things. If we don't know what the cause is, the number one thing you're gonna do is to find the cause. If I do a CBC on someone and they shouldn't have any reason why their hemoglobin is low and I'm getting a hemoglobin of 7.2, I need to look and see what's going on. Are they bleeding somewhere? Do they have leukemia? What is going on? So I need to find the cause. Now, if they came in with a gunshot wound and their hemoglobin is 6.4, yeah, I kind of know the cause. All right, they're bleeding. All right. If it is, remember I told you your red flags, less than 10, be a little cautious and just kind of watch for hypoxia, right? Because we said everything with red blood cells, hemoglobin, hematocrit, that's all oxygen, right? I'm going to write that on here because I know I've said it 100 times, but I need you to just know it, okay? Hold on. All right, this is an oxygen issue. This is an oxygen issue. This is an oxygen issue, okay? Not a bleeding issue, okay? All right. Now, the only thing that's weird, and this is why people get confused on this, a low hemoglobin and hematocrit or anemia can cause increased bruising. That's just because your blood is thinner, you get a little trauma here, and it can cause bruises, but your patient's not gonna bleed out from a bruise. So a sign and symptom of anemia is increased bruising, but they're not having internal bleeding, they're not losing something somewhere. Our biggest risk is hypoxia, not bleeding. Do you understand the difference, okay? So less than 10, I'm gonna be cautious. I'm gonna be like, look, we need to find out what's going on. This may be an iron deficiency anemia issue. This could be a sickle cell thing. We need to find out what you've got so we know how to treat you. Less than 7, that's our red flag, right? So less than 7, they need to be getting a blood transfusion, okay? And that's because the hemoglobin and hematocrit levels are gonna go so low that we know their oxygen is going to be impacted below that point. So we need to have them on an SpO2 so I know if their oxygen is affected, and then administer O2 if it is low, okay? But do not administer O2 if you don't know if the patient's O2 is low. We don't just slap oxygen on everybody, okay? And fun fact for nursing school, oxygen is hardly ever the answer unless they give you a very specific SpO2. Remember in nursing school, you're matching up nursing care with signs and symptoms, okay? So if they just tell you a patient comes in with COPD, what would you do first? Put them on oxygen. But why? They're chronically hypoxic anyway. So unless they gave me an SpO2 and said, your COPD patient comes in with an SpO2 of 84, yeah, okay, I'm gonna throw them on oxygen. But oxygen is a prescription. You have to remember that. So you can't just throw it on everybody because you think they're having trouble breathing. That's the other big nursing exam thing I'll tell you. Just because it says they're having trouble breathing does not mean you throw oxygen on everybody, okay? Because you could actually harm some people by giving oxygen. Trouble breathing, I need to find out why. Is it an asthma attack? Because an oxygen may not help me all that much. I really need albuterol to open up the airways. Because in asthma, you've got bronchoconstriction, so I can give you oxygen all day long, but nothing's going in there, right? So that doesn't match up with my prescription. Match up your answers on the exam with what they give you, okay? Now, if they say a patient comes in, their hemoglobin is 6, their SpO2 is 92%. What are you gonna do? Yes, I'm gonna put that person on oxygen because I have a rationale behind why I need to do it, okay? So, less than 7, we're gonna be giving a blood transfusion. We're gonna be doing SpO2. We're gonna be doing O2 most likely if they are hypoxic, okay? All right, do we understand hemoglobin and hematocrit? Do we know our red flags? Do we know what we're looking for? Do we got this? Yep, awesome, okay. Let's move on to the ones that nobody ever talks about and they're like so forgotten and so sad over here. MCV, MCH, and our MCHC. I put them all together. You do not have to know lab values for these. They will never ask you them. I don't even know them. I've been a nurse for like 1,000 years, okay? Not that long because I'm obviously super young and in my early 20s, but anyhow. So let's just talk about what they are. All these mean the MCV, MCH, and MCHC. The only thing that they mean is the size of the red blood cells, okay? So if those levels come back high on the CBC, then that means that the size of those are high, okay? So it means that they're big. That's all it means. Now, does that mean that they're super effective? No, because you've seen some like big dudes who aren't effective at a whole bunch of things, okay? So the size doesn't matter. It's the hemoglobin that can bind to that size that really matters, all right? So the size will give us an indication. The only reason why we use MCV, MCH, and MCHC is to determine what kind of anemia that they have, because there are different characteristics of the sizes and what they look like that will tell us what kind of anemia, okay? So if the size of my red blood cells are really big, remember we said just because they're big doesn't mean they work well. I could make so many jokes right now that I will not, okay? So if they're big, that's called macrocytic. So macro means big, right? Cytic means cell. Anemia. So you can actually have a form of anemia, okay, where they have very big red blood cells, but they are not effective. That's called macrocytic anemia, okay? So if I thought my patient had anemia, maybe hemoglobin and hematocrit were a little off, maybe red blood cells were a little off, patient was bruising easily, patient's complaining of fatigue and they're tired all the time, I'm going to look at the CBC and see if the size is big. They could have macrocytic anemia, okay? All right. They can also have vitamin 12 deficiency. Now let's talk about that for a second because this is weird. Vitamin 12 deficiency can cause something called pernicious anemia, right? You have something called intrinsic factor in your stomach. You have to produce intrinsic factor from your stomach to bind to vitamin B12. B12, remember we talked about earlier, is necessary for healthy red blood cells, all right? So if you have a lack of intrinsic factor, which that's the root cause of pernicious anemia, you don't have intrinsic factor, it can't bind to your B12 can't be used, so you're making unhealthy red blood cells. It may try to increase the size of the red blood cells, saying like, oh, maybe we can get more hemoglobin if I just make them bigger, but it's not effective because they're not healthy, so they can't bind more hemoglobin. Do you see what I mean? So that's how the vitamin B12 deficiency can cause an increase in the size. That's your body's compensatory mechanism to try to fix the problem. What was the other mineral that I told you is really important for our bodies to make healthy red blood cells? We said iron, vitamin B12, and folic acid. So if you have a folic acid deficiency, you're not making healthy red blood cells, okay? You're not making healthy red blood cells, your body's going to compensate by making them larger even though they don't work as well, okay? All right, let's look at low. So low MCV, MCH, MCHC, that is going to mean that they're small, okay? So what is it called whenever they're super tiny small? Well, if this was called macrocytic anemia, then this would be called microcytic anemia, okay? So that's where you typically have deficiencies in all kinds of different things, or your body is making red blood cells, but they're making them super small. The hemoglobin can't bind to them because there's not enough space. Therefore, you're still going to be at risk of hypoxia, okay? Do we understand so far? Okay. You can also see a small size if you have iron deficiency anemia. Iron is necessary, remember, to make healthy red blood cells, but you have to have iron for the hemoglobin to bind to. And so if there's no iron, it can't make this healthy red blood cell. It may just produce a bunch of small, ineffective red blood cells. Okay? So knowing that, I want you guys to tell me what your nursing care is going to look like. But you got to think, we're really looking for a cause here. And either way, they're going to have some kind of anemia. So our plan of care, our nursing care, is going to be the same as it was for anemia, right? Which means we're going to have to be on an SpO2 monitor. We're going to give them O2 if their SpO2 is low, okay? We're going to plan frequent rest periods, right? We're going to give them supplements, but only of what they need, okay? So remember I said, like, if they have sickle cell, don't give them iron. So we have to find out what the root cause is of this anemia and then treat it appropriately. So they may either be on, they may be on some of these, but not all of them, and I'm going to write down what supplements we may need to do. We may need to do vitamin B12 if they have pernicious anemia. We will do iron if they have iron deficiency anemia. and we will do folic acid if they have a deficiency in folic acid, okay? But you probably will not be on all of those, but we have to match up the cause. Do we get it? Are you with me? Okay? All right. Let's talk about our platelets. Now, this whole time we've been talking about oxygen, 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 right? Now we're finally getting to the bleeding, all right? So platelets' job is to clot, right? So what happens if there's something wrong with my platelets? This is clot. Correction. Okay. What is a normal platelet level? And then I want you guys to tell me kind of what you wrote in this space here. What does it mean to be high? What does it mean to be low? What is the term called? All right, Allison's saying 150 to 400,000. I like that level, okay? You may see some places go from 150 to 450, but I like what you chose. 150 to 400 is pretty good. I'm liking it, okay? So we're gonna do 150 to 400. Keep in mind that this is the same as the white blood cell count as far as in thousands. So you may hear people say the platelet count's 150,000. That means 150. Don't be like, oh my God, they have so many platelets, they're gonna just clot and die. But that's not what it means, okay? These go in thousands too, but when you get the CBC, it'll just say 150, okay? So I wanna be clear on that. All right, so if my platelet levels are high, now this is a little tricky and weird, okay, but we're gonna talk about it. So platelets are still a solid portion of the blood, right? So the viscosity may increase a little bit, but it's not going to cause the super big hypertension like we saw with red blood cells, okay? So platelets are high. That means we're really, really good at clotting, which means you are at risk for clotting, okay? Now follow me through with this one because it's a little odd, okay? When you have super high platelets, it also can mean you're at risk for bleeding. Wait, what? Why? Oh God, why did I do this to you? Okay. Usually if your body is making a whole bunch of platelets, if your platelet level is really high, that usually means there's something wrong. Your body's not supposed to be making a bunch of platelets like that. That usually means there's some kind of cancerous process, and we talked about cancerous processes earlier. If you have a cancerous process and it's overproducing cells, those cells are ineffective and they don't work. So you may be producing 500,000 platelets, but they're all immature or they don't work to clot, so you may have a risk for bleeding, okay? So it could go either way depending on what the underlying cause is, but we do worry about clotting, we do worry about bleeding, so we're gonna worry about both sides. Does that make sense, okay? All right, and then Sunny said thrombocytosis, okay, which is good. Okay, so we're gonna do thrombocytosis, okay. That's what that means. All right, tell me about low platelets. What is that? What are we worried about? What's it called? Low platelets, since platelets' job is to clot, your big risk is risk for bleeding. This is huge, okay? Now, I want to kind of talk about normal levels, though, because you may get some weird questions asked in nursing school, and I want to make sure I cover it. Let me talk about it in just a second, because there are a couple of other things that can cause this. Chemotherapy can cause it, because remember, chemotherapy wipes out all our cells, not just the chemo or the cancer cells. So it's going to wipe out red blood cells, platelets, white blood cells, all of that, right? So chemotherapy can cause us to have a very low platelet count. There's also a disease process called ITP, if anybody knows what that is. Idiopathic thrombocytic purpura. So they don't really know why you get it, which is why it's called idiopathic. So I did not know this through nursing school, but if it says idiopathic, it means they don't know why, which is actually kind of nice because then you won't get tested on how it works because we don't know, okay? So idiopathic thrombocytic purpura, they wake up. I've had some kids that have had this, and there's also one that's called HSP, which is a Heinlein purpura. It's very weird. Anyway, the kids will like wake up from a nap and they look like they've just been beat to hell. They're absolutely covered in bruises and purpura everywhere. Parents rush them to the ER, think somebody has abused them, but it's actually a very quick onset where the platelets tank. ITP, we have to rule out everything else like leukemia, right? Because low platelets can be caused from leukemia. We have to rule out some other big diseases before we'd say like, okay, we've ruled out everything else. This is ITP. And there's some kids who can get ITP, or adults can happen too. They get low platelets every time they get sick for a period of time, even after the ITP resolves. There was a kid I had when I worked at Texas Children's, and oh my gosh, it killed me because I was a new nurse practitioner, and so I know my normal lab levels, right? 150 to 400. The kid comes in and he had strep throat or something, and his mom's like, you know what, he's had ITP. We do a CBC every time he comes in and he's sick just to check it. So I check a CBC and it comes back as like 36, and I'm like, ugh. So I'm freaking out. I go tell the mom, and she's like, nah, that's fine. That's about what he normally runs when he's sick. And I'm inside like internally screaming but trying to be cool. So I'm like, okay, well, please don't let him play contact sports, you know, like I'm freaking out, okay? But there's going to be different normals for everybody. This is a normal for like normal healthy people, okay? Now, if I have a chemo patient, they will never hit 150 to 400. They're on chemo. We don't freak out until they're below 50. And even then, sometimes we don't do platelet transfusions. Isn't that scary? Sometimes they wait till they're 25, not age, but 25 platelets, okay? So if this is really high, if platelets are high, we really need to find out why, because it's not normal for that to happen. There are a lot of times where this can be a cancerous process, and so we do have to find out what's going on. So we need to run a whole bunch more labs to figure out why. And then we need to put them on basically like clotting precautions, which there's not really clotting precautions, but you're going to tell them, you know, you need to report sudden shortness of breath with chest pain. That would be a PE. You need to report severe headache, or you need to report, you know, these kind of things where we would expect to see a clot. Let me know if there's swelling in the leg. So you need to really educate your patients on signs and symptoms of clots, okay? And tell them not to smoke, right? Because that's going to increase their risk of clots, okay? In nursing school, there's never a time where you don't pick stop smoking. And I swear they love that answer so much. There was a question on a nursing exam one time, and I just nearly died, but I didn't because I'm obviously here. But it said something like your patient had peripheral artery disease with a history of diabetes, and they've been a smoker for the past like 400 years, I don't know. And your patient is about to be wheeled off to get an above the knee amputation. What's your priority? And it was like, tell the patient to stop smoking. I'm like, but it was, okay? So there's never a time where you don't pick stop smoking, and there's never a time where you don't pick good hand washing, okay? If this is low, what are we gonna do? You'll tell me there should be some big precautions that we do for low platelets. We're gonna majorly put them on bleeding precautions, okay? Y'all tell me what you know is included in bleeding precautions. And while you're doing that, usually if the platelets go less than 50, we're going to do a platelet transfusion. That way they don't get whole blood, they don't get stuff they don't need, they just get a platelet transfusion, okay? Y'all tell me what's included in bleeding precautions. Most definitely no contact sports. All right, no contact sports for low platelets because their risk for bleeding is huge, okay? What else are we going to do? All right, Chrissy said safety with shaving, so you want to make sure that they use an electric razor and not a straight razor. What else are we going to do? Y'all know bleeding precautions, right? Surely. Okay, so other bleeding precautions. No rectal temps. My dear God, that is the last way that I want to die, is having a rectal bleed. Okay, I don't know, thank you. So don't do rectal temps, because you can actually cause a little tear in the rectum and they go bleed out, and that's, you don't do that. That's rude. You shouldn't be doing rectal temps anyway, but that's included in bleeding precautions, okay? So electric razor, no straight razor. Soft toothbrush, or use a toothette because their gums can bleed really bad, okay? You need to check all the body fluids for blood. So check in their emesis if they're throwing up. We'll do hemocolt so we can check the stool, all right? We will check for hematocysts, okay? So we'll check and see if they cough, are they bleeding, and tell them to report that. Do they see whenever they pee, is there blood in the urine? We need to report that. We need to monitor their urine. So all of that is included. We're looking at different places to make sure that they're not bleeding. We do no IV, no IM, no sticks if at all possible. Now the patient's gonna have to have an IV if they're at risk for bleeding. I get that. But what they mean is don't try to stick them 7 times. Don't be like, oh, this IV's been in a couple days, let's stick them on the other side. Like if the IV's working, you stop and leave it alone. Another question they like to ask, which I think this is crazy, but this happens all the time in nursing exams. If they're on bleeding precautions and they need vaccinations, okay, we can give the IM vaccinations as sub-Q, because the sub-Q doesn't bleed, IM does. I don't know why this is a thing, but this is a thing. So give the IM vaccinations sub-Q, because we do want to protect them against infection. I mean, they still need vaccinations, but we don't want them to bleed. If they have very low platelets and there is a bleed, you need to put pressure on it for 10 to 15 minutes and apply ice to vasoconstrict. That's how we protect it, all right? So no rectal temps, right? Electric razors, not straight. soft bristle toothbrush, okay? Check everything for bleeding. They are going to be risk for falls. You don't want them up and moving around. Make sure you clear the floor, because if they fall and they hit their head, they may have a really bad head bleed. We don't need that. One of the other big ones that's included in bleeding precautions, which is sort of weird, is manage their constipation. Give stool softeners. That's included in bleeding precautions, because if they are constipated and they have a large stool, you could get like a little teeny tiny anal fissure, a little tear. And most people, like when you just like wipe, there's a little bit of blood and you're like, oh, that's kind of creepy, but that's what happened. But in patients that have bleeding precautions, they may start like hemorrhaging from the rectum, and we already said earlier, that's not a good idea, okay? So don't do that. So make sure they're on the stool softener and you're monitoring their bowel movements, okay? Anything else I missed in bleeding precautions? Let's see, y'all said no IM injections, patient education for bleeds, dental hygiene. Yes, y'all nailed it. All right, so this is the CBC decoded. Do we understand everything? If so, I'm going to take a picture of this for sure. And then I'm going to show you guys something that I made that can kind of help you remember some of these big lab levels. If it helps you, great. If it doesn't, right. But I like having things kind of in order so I can remember stuff. So here's, I'm going to write it and then I'm going to explain it to you. I'll put it up here. A second, okay. All right, here's my easiest way to remember the CBC, and I write it like a stair step, okay? All right, all my numbers are gonna match each other here. So 4 to 5, what is normal 4 to 5? That is our red blood cell count, right? Bring the 5 down, 5 to 11-ish, that's my white blood cell count, okay? Bring the 11 down, 11 to 15, that's my hemoglobin. Anytime you want to know what your hematocrit is, you multiply your hemoglobin times 3. So that would give me my hematocrit, which will be somewhere between 33 to 45. That's my HCT. Bring the 15 down, add a 0 to it to 400, and that's my platelet level. It's worked like a charm for me. If it works for you, that is fantastic. If it doesn't, I'll come up with something else that you like better, okay? And I'll take a picture of that more up close so you can see it. Actually, let me see if I can move closer so you can see it. And then I'll take a picture. Y'all can see that? Okay, so we've got 4 to 5, 5 to 11, 11 to 15, and then bring the 15 down, 150 to 400, and that will give you your whole CBC and everything you need to know. Okay? Shireen, amen. Amen, sister, I feel you. All right? Okay, that is going to conclude everything for today. Be sure to click the link on this page in the next 24 hours if you want to do our next seminar, and you want to get that discount code. It'll only be open for 24 hours, so be sure you guys register for that if you want to come. I'm going to be doing, one of the biggest things I see that students don't know is albumin. Albumin is the basic of all fluid balance, of all electrolyte balance, of all protein, of all everything. So we're going to be talking about albumin, bilirubin. We're going to be talking about our alk phos levels, our liver function test. We're going to be doing everything liver GI-ish. So you want to make sure that you get that. Clotting factors, vitamin K, we're doing all of that. That'll be next week. There's a link to sign up for only $5 in this session, okay? So you want to make sure you click on that link and you register. It's only going to be up for 24 hours, and this whole session will only be up for 24 hours. Everybody else has to pay for it. You guys don't have to pay as much. We will end up releasing this video, but it will be in our videos on demand. So if you guys haven't checked that out, we have a ton of videos just like this. They're all on our website if you want to get them. If you have certain subjects that you're studying in nursing school, go find that subject on our website. You can just get that video and study your rear ends off and learn all the things with us. So we've got a ton of them on there. We also have a lifetime membership. So if you're just like, give me all the videos that you've got, it can save you a ton of money by just getting the lifetime membership. But all this information is on our website. So I would encourage you to go and look and see and learn and do all these things. I say really inappropriate things on most of the videos. So we're going to just go ahead and pray for my soul before y'all watch anymore. Okay. So the link will be up for 24 hours. The video will be up for 24 hours. And then next week we will be doing the Decoding Lab Values Part 2, Liver and GI. Hope to see you there. Okay, you guys are great today. Maybe next time we will see ya. Bye, y'all.